afternoon everybody. শোনা যাচ্ছে তো?
শোনা যাচ্ছে, একটু ভিজিবল হলে ভালো হয় তো।
এটা ভিজিবল হবো?
ও এখানে হবে না, আচ্ছা 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 আচ্ছা, ঠিক আছে ঠিক আছে। Please continue.
Thank you, Dr. Bandyopadhyay, for organizing this penultimate clinical meeting of this academic session of West Bengal Academy of Pediatrics. And I think there are very good number of cases with brisk presentations and with crisp message. And I would like to hand over the presentation to Dr. Bandyopadhyay to continue the session. Thank you. Dr. Bandyopadhyay, please.
A very good afternoon to all the distinguished audience here, and it is a pleasure for the Department of Pediatrics, B.R. Singh Railway Hospital, to be associated with Indian Academy of Pediatrics West Bengal branch, which we feel is an extended family, and from time to time we always receive the support and blessings from IAP West Bengal. And this endeavor on our part to present these cases, short cases, it was possible only because our present chairholder of the IIP West Bengal, Dr. Sushmita Banerjee, kindly permitted us, and we will be presenting 5 short cases. These will be presented by our DNB PGTs, and it is a teamwork, no doubt. All the doctors of our department, even the doctors of other associated departments, including pathology, radiology, we work in a cohesion so that we can render comprehensive healthcare to the railway beneficiary. And we also are indebted to the administration of B.R. Singh Railway Hospital for allowing us to hold this today's program. So our senior resident, Dr. Mononita, will be conducting the stage show with the DNB PGTs, and we all will be there. And I am really indebted to Manglikda and the other senior faculties of IIP for coming here and blessing us in today's program. So thank you. I call upon Dr. Mononita to kindly start the program.
Good afternoon, everyone. So we'll start with the presentations. Our first presentation is by Dr. Sankati Suma on a hematological googly. Respected faculty members and my colleagues, good afternoon to everyone. Myself, Dr. Sankati Suma. I just want to enlighten a case which we came across, which is actually a hematological googly. So, a 4-year-old boy, Raghavendra Das, a born of non-consanguineous marriage, presented with chief complaints of fever for 4 days, cough and cold for 4 days, and the presenting complaints were child was completely apparently normal 4 days back, and then presented with a fever of a moderate grade, which was intermittent, which was associated with leg pain and not associated with any rash, chills, and rigor. And the cough was a mild cough and cold, which was for 4 days, and it is also intermittent, not associated with any seasonal or diurnal variations. Bowel and bladder habits were completely normal, and there were no any history of spontaneous bleedings. Coming to the past history, the child had admitted in September 2022 at local hospital with complaining of tiredness and lethargy, even with a mild to moderate physical activity, and the child was diagnosed with G6PD deficiency and with low hemoglobin level, received 1 unit of PRBC and treated conservatively and got discharged. Coming to the family history, nothing significant. Birth history, the child born by normal vaginal delivery, late preterm, appropriate for gestational age, and had neonatal jaundice at day 3 and received phototherapy for 2 days. Developmental and immunization history up to the age. On examination, child is completely all right, alert and playful, and all the vitals were normal, and the child is completely hemodynamically stable. Coming to the anthropometry, all the anthropometric parameters were within the normal limits. And we further examined, we came to know that the child is paler, and we could find multiple lymph nodes of 1 centimeter, multiple cervical lymph nodes of 1 centimeter, and inguinal lymph nodes of 1.5 centimeters were present. And per abdominal examination, we could find the abdomen was soft and non-tender, and we could find hepatomegaly of 3 centimeters, which is below the right costal margin, and the surface was smooth and margins were round. And there is a splenomegaly, which is 5 centimeters. And coming to other systemic examination, the respiratory system, CVS, CNS are completely within a normal limits. So after this history and clinical examination, we came to a differential diagnosis, like it could be of hemolytic anemia, could be of leukemias, could be acquired infections, or could be acquired immunodeficiencies. So for further evaluation, we went to the investigations. So these are the investigation part. I just want to show the CBC of the child, where the child had admitted previously at the local hospital, and the CBC after admission in our hospital. The CBC of the child at local hospital was, hemoglobin was found out to be 7.1, and the total WBC was found out to be 3,900, which is in the lower part only. And lymphocytes are more than neutrophils. So there is a bicytopenia, and the peripheral smear is completely normocytic, normochromic, but the retic count is bit increased, which is 12.2. Corrected retic is also increased, which is 7.8. Coming to our CBC, the hemoglobin, we could find it 7.9, and the WBC is normal only. And we could also find lymphocytes are more than neutrophils, and we could find the platelets are 70,000. So we also found bicytopenia, but the markers are different compared to the previous admission. But coming to our peripheral smear, we could find atypical mononuclear cells of 26% with microcytic hypochromic anemia. So I just want to enlighten with this CBC. The child had bicytopenia previously, and we had also had bicytopenia now. So, but previously the child peripheral smear was completely all right. But right now, within a 2 months gap, we can see the peripheral smear abnormal nuclear cells, which were about 26%, which is a significant. Coming to the other investigations, LFT is completely within normal limits, including the bilirubin level. RFT is also within normal limits. Coagulation profile is also normal. LDH, DCT, HPLC is also normal limit. We did all these things to rule out hemolytic causes. We again, for further confirmation, we again did the G6PD levels, quantitative assay. We could find it is low. Serology is normal, and for the further evaluation of infection, blood culture and urine culture showed no growth, and chest X-ray is completely normal. So with all these investigations, we had ruled out hemolytic anemias, we ruled out acquired infections, we ruled out acquired immunodeficiencies. So we left with leukemias. So for further confirmation of leukemia, we went with bone marrow examination. So this is the picture of bone marrow aspiration, which showed 84% of the blast cells and increase in myeloid to erythroid ratio. You can see in the image, the blast cells are, you get plenty of blast cells, and in the blast cells, increased nuclear to cytoplasmic ratio with open chromatin. Coming to immunophenotyping, immunophenotyping showed positive for CD19, CD79A, CD10, which is suggestive of B cell lineage, and karyotyping, which showed G banding normal. So with the available investigations, we came to a final diagnosis, B cell ALL with G6PD deficiency. Further genetic testing reports are pending. So we managed this child, treated conservatively for cough and cold, given 1 unit of PRBC, started induction chemotherapy with prednisolone, vincristine, daunorubicin, and L-asparaginase, as well as intrathecal methotrexate. So with my case, the take-home message I just want to say is, any bicytopenia should be evaluated thoroughly. If we could have just seen that hemoglobin 7.9 and the platelets just 19,000 without doing any peripheral smear, and with the past history of underlying G6PD deficiency, if we thought that hemoglobin was low because of a G6PD deficiency, we could have lost this child to ALL and its complications. So I just want to enlighten that as more than 2 hematological conditions may coexist. One should not be get biased. Yes, this child have this, so we should not needed further evaluation. And one more thing, always lab parameter should always be interpreted in the light of clinical features of the patient. Why I want to say this point is because this child has G6PD deficiency, but the hemoglobin is low. Is not because of the G6PD deficiency. Why? Because the child does not have any signs and symptoms of hemolysis, say like hemoglobinuria, jaundice, and the lab parameters does not suggest you of any hemolysis. So I just want to enlighten that if we should be evaluated, though the child has underlying one hematological condition. So coming to the discussion part, G6PD deficiency is seen in 78.37% of patients with ALL. Many studies has been suggested this percentage, while it is normal in other patients, and variation of G6PD levels depends on the percentage of the myelocytes. And it depends on the leukocytes percentage of the ALL child. So leukocyte G6PD, it also used as a diagnostic as well as prognostic tool of ALL. How it can be used, like if the karyotype for G6PD deficiency is normal and G6PD levels are normal, the child of ALL will have good prognosis. If the karyotype is normal, but the G6PD levels are low, then the child will have intermediate prognosis. If the karyotype for G6PD is abnormal, and if we find low G6PD levels, the child will have poor prognosis for ALL. So with all this discussion, I just want to say only the one point is, so G6PD is not that rare in a case of ALL. So if a child with ALL, if a child with G6PD deficiency having low hemoglobin, don't get biased with that. The low hemoglobin is only because of G6PD deficiency. And we should evaluate further clearly in a child if we find any bicytopenias. These are the studies supporting G6PD activity in a child with acute leukemias. Thank you, everyone.
What was the platelet level at the first admission?
Normal, sir.
So at
No.
that time, I think it was 6 lakhs.
4 lakhs, sir.
4 lakhs.
Yes, sir.
And now it was 75,000.
90,000.
90,000. That was a significant fall.
Yes, sir.
Can I ask you, in your second last slide, you showed the karyotyping is also important.
Yes, ma'am.
Why the karyotyping?
There are few researchers saying that G6PD with ALL association, G6PD levels can be used, not only levels, G6
Abnormal karyotype. What type of abnormal?
Karyotype for G6PD mutations, ma'am.
G6PD mutation.
Yes, ma'am. It's not for karyotype of ALL, it's karyotype for G6PD, they are saying, ma'am.
Can karyotype tell you about G6PD deficiency?
Deficiency, it will not say, sir. It will say the type of mutation.
Can karyotype tell you any mutation?
An abnormal chromosome, it can say. So, like, if
Not mutation.
not mutations. Now, abnormal chromosomes, if present, what chromosomes can lead to? Yes, it can answer.
Maybe mutation analysis.
Yes, ma'am. Mutation, not karyotype, abnormal mutation analysis.
What was the cause of the microcytic hypothermic anemia? Should we expect this type of cases a
Normocytic normochromic anemia.
What was the cause of microcytic hypothermic? See the first slide, yes.
Yes, ma'am. We initial peripheral smear, we showed microcytic hypochromic anemia. We did iron study profile, but it is in the normal limits only, ma'am. And
It is anemia of chronic insufficiency, chronic inflammation.
it could be, ma'am, because of the child inflammatory markers are bit CRP bit rise at the.
What happened in between these 2 months? Was the child
Completely all right.
sort of homeopathy or any treatment outside?
Nothing, ma'am. The child was completely all right, not receiving any medications. And the child was properly advised not to take any medications which cause hemolysis in case of G6PD deficiency.
No fever, nothing in between.
No, ma'am.
It's absolutely normal.
2 months completely all right.
Child was lethargic and quite
Getting
prone to tiredness in the first episode.
even with the moderate physical
That
activity.
improved in between.
Yeah, after getting the blood transfusion at the
You got
initial.
a blood transfusion in the
Yes,
first episode,
yes, sir. Yes, sir.
And you got a pre-RBC now.
Yes, sir.
Okay, thank you. Let's move on.
Thank you.
Thank you for the nice interactions. It was really a mind-boggling case.
You have to have a 10 for ALL.
A mother,
Next thing was important.
mothers are so conscious these days, even in ward, admitted for plain viral fever, they are also worried. They are saying, sir, in our locality, there was a child with these symptoms and he landed up in malignancy, blood cancer. So this type of awareness is growing.
One thing I was just want to know, the first admission, when the hemoglobin 7, so what was the cause of anemia at that time?
That time they diagnosed it as a cause of G6PD deficiency triggered by some factor and that led to hemolysis and anemia, and for that blood transfusion is given in a city hospital, not this hospital, some other hospital.
And at that point, it was 12%.
Yeah.
So we can't neglect that report also, isn't it?
Yes.
Let it count 12%. So there probably was some. There was some.
G6PD was the incrementing factor that was there, and the underground, that the disease that was lurking, it was missed somehow. Because in our setup also, we did the peripheral blood, it was completely normal. No blast cells, no increased cells, only platelet was down, low.
One more thing I just want to say that on previous admission, the child had hepatosplenomegaly as well as lymph nodes also. But they were ignored and concentrating only on the G6PD levels with increased retic count. Not significant, just palpable everywhere. Diffuse node, only diffuse lymph nodes were palpable.
So they were not very raw also.
Yes, because peripheral smear also found out to be normal.
We can always put blames.
So just go the next one.
If you are having a very active marrow, your white cells should be on the higher end. But it was low. But then, you know,
শেয়ার করে দিয়েছি সোমনাথ, এটা শেয়ার হয়েছে?
শেয়ার হয়েছে, স্লাইড শোটা করুন।
স্লাইড শো করতে হবে।
হ্যাঁ, slide show করবেন। চেয়ার থাকতো পুরো থাকতো।
না স্লাইড, আচ্ছা ওইটাতে স্লাইড শো টেপ এটাতে, এটা না এটাতে সেট আপ স্লাইড ছিল, এটা ওইটাতে গেল। আচ্ছা এসছে বারে
এলো তো আবার চলে গেল তো।
চলে গেল। না ওখানে অনলাইনে এসেছে।
না,
এই রাজেশ দেখ এইখান থেকে
No.
Rare case of fever.
नहीं next
না এটা না।
Put it on, Jyoti, doesn't matter about the order.
কোথায় চলে গেল? আচ্ছা যেটা আছে
no
না
ওটা না
ওটাকে অফ কর। যাও कौन एक्सपर्ट है? ऐसा करो।
किधर है?
ये वाला ही।
यहाँ तो नहीं जा रहा।
यहाँ से
वैसे प्रेजेंट कर रहा हूँ
ना ना आ जाएगा।
कि हाइब्रिड আমরা অনলাইন অনলাইনে শুরু করতে চাই অনেকে আছে অনেকে আছে অনলাইন সো উই কন্টিনিউ স্টপ এবার ডেস্কটা এখানে করো না এটা
फ्रॉम करंट सेट करो
এটা করলেই হবে এটা
नहीं
করো
हो रहा है
नहीं हो रहा है अच्छा रहने दो वैसे ही रहने दो
ज्यादा विंडोज ओपन हो गया तो गड़बड़। सब क्लोज कर दो, सब क्लोज करके नया करके करो। PC Windows open है।
अच्छा इधर है
তোমরা কি এমনি স্লাইডটা দেখতে পাচ্ছ স্লাইড শো না হলে কিছু প্রবলেম আছে এমনি পাওয়ার পয়েন্টটা দেখতে পাচ্ছ শেয়ারই হয়নি বলছে এবার এবার দেখো আচ্ছা শেয়ার হয়নি একটু গো ব্যাক এন্ড শেয়ার এটা খোলা থাক এটা ছোট করো এটা ছোট করো দেন গো টু
इसको छोटा
এটাও ছোট করো এবার গো টু দ্য জুম হ্যাঁ জুম এখানে বড়
यहाँ पर करो। हाँ बड़ा इसमें
এবার
ये
করো
share-
শেয়ার স্ক্রিন
share। हाँ अभी लो।
এবার কোনটা এটা রেয়ার কেস অফ ফিভার
দুটো খোলা আছে গো, একটা বন্ধ করতে হবে।
এবার একদম
ঠিক
ঠিক
আছে।
আছে বলছি চল
আমরা তো
ध्यान नहीं
আচ্ছা
ওখানে
দেখ
ওখানে দেখে করো
ওকে এবার কি হয় এবার
नहीं आ रहा
দেখা যাচ্ছে।
will it go forward and back
हाँ मैम ऐसे तो
হ্যাঁ দেখা যাচ্ছে পরের স্লাইডে দেখি পরের স্ক্রিনটা যান পরের স্লাইডটা সেকেন্ড স্লাইডে
সেকেন্ড স্লাইড যাও।
अच्छे ना
এটা অন্য আরেকটা
this
এটা
one is
আরেকটা, হ্যাঁ।
plain
রিয়ার
দুটো
কেস
খুল
অফ
গিয়া
ফিভারের
না?
সেকেন্ড
এবারে,
স্লাইডটা
हाँ,
হ্যাঁ ঠিক আছে ফার্স্ট স্লাইডে চলে হ্যাঁ ঠিক আছে একদম ঠিক
ঠিক
আছে
আছে। আর দুটো খুলে গেছে বলে কথা।
তোমাদের কি ল্যাপটপ আছে
Our next speaker is Dr. Sandeep with his presentation, a rare case of fever in a neonate.
ওই যে রোপ আছে
Good afternoon. My name is Dr. Sandeep. I'm going to present a rare case of fever in a unit. History: a male baby born to D.D. Kundu, who is a resident of Rajmalhat, Hooghly district, aged 7 days, was brought with chief complaints of fever since 2 days, with poor sucking and feed intolerance, reduced urine output. The birth history: the child was a first order child delivered at term by LFCS on 22 October due to non-progression of labor. The child cried spontaneously at birth. The birth weight was 2.83 kgs. The maternal history: she was a booked case. She had regular antenatal checkups. She was a known case of hypothyroidism on tablet Eltroxin. Her anomaly scan was normal. The baby was shifted to mother's side and discharged on 26 October on exclusive breastfeeding. The discharge weight was 2.53 kgs. On examination, the weight was 2.87 kgs and OFC 33 centimeters. Temperature was 100 degrees Fahrenheit. CRA was average. Capillary CRT was less than 3 seconds. Respiratory rate was 40 per minute. Heart rate was 120 per minute. SpO2 98% with room air. Chest was bilateral air entry was positive. CVS S1 S2 heard, no murmurs. Per abdomen soft, no organomegaly, no distension. CBG was 91. Anterior frontal LA, not bulging.
What is CRA?
Capillary reflex activity.
What?
Cry reflex activity, sir. Cry reflex activity. CRT is a capillary refill time. And course in NICU. The baby was started given bolus 10 ml per kg IV fluid, and then she was started on maintenance. with intermittent breastfeeding. Blood was sent for relevant investigations. IV antibiotics were started as sepsis screen was positive. Baby had reduced urine output 0.34 ml per kg per hour over last 8 hours. With the sodium 155, blood urea was 121, creat was 1.4, potassium was 5.4. The DD was hypernatremic dehydration due to pre-renal AKI. The input-output chart was maintained and BP monitored. The BB was kept on 100% IV fluid with isolate P, 120 ml per kg. The baby had thrombocytopenia on day 4, which had petechial spots over body, which subsided without any intervention. A differential diagnosis by this late onset neonatal sepsis, dengue, malaria, dehydration fever, or torch infections. The BB on investigations, the BB was tested NS1-EG positive for dengue, and later IgM dengue was conducted. It was also positive. Investigations. The baby initially the baby had high urea, creat, and sodium potassium levels, which gradually reduced by day 3 and 4, day 4 and 5.
Can you go back?
Mother had no history of dengue in antenatal period. She was tested negative for dengue NS1-EG and IgM during this period. Blood culture and sensitivity showed no growth, so IV antibiotics were stopped. Breastfeeding was fully restored by day 3. USG, abdomen, and cranium were done, which were normal. Torch screening was done, which was normal. The baby improved clinically with urine output greater than 1.5 ml per kg per hour, and platelet count gradually increased by day 5 of admission. As urea, creat, sodium levels, and other blood parameters improved, the baby was discharged in a stable condition while on exclusive breastfeeding and gaining weight. Regarding neonatal dengue, it may be vertical transmission or horizontal transmission. In vertical transmission, in the neonates with mother having dengue in perinatal period. So in horizontal transmission, by mosquito bite in neonates born to non-immune mother. In vertical transmission, as a maternally transmitted antibodies offer protection to the baby. But in horizontal transmission, the absence of antibodies make baby vulnerable to dengue hemorrhagic fever and dengue shock syndrome. Although several cases are reported by vertical transmission, there is a little literature regarding horizontal transmission of dengue. And take home message, dengue should be kept as a DD in neonates with fever, rash, and thrombocytopenia. Pregnant women and neonates should be protected in endemic areas from mosquito bite by using mosquito nets and other preventable measures. Dengue, neonatal dengue can be life-threatening by causing dengue hemorrhagic fever and dengue shock syndrome. Thank you.
So the dengue report was negative.
Sir.
Mother also did not have any.
Anti-dengue IgM will be conducted in.
Suppose that is also negative. Suppose it didn't have dengue at all.
Sepsis, it can be sepsis or any torch infection.
CRP was just a.
Sir.
Very marginal.
I think come inside and answer the questions. When we go out, we try to note them.
Okay, sir.
Test for the mother's breast milk sodium.
No, sir. Okay.
That's one aspect one must look into. The breast milk sodium is clinical picture exactly what happened now. But with hypernatremia, so you know.
The dehydration rate is not quite matching because the baby didn't lost any weight. Actually, baby lost about 10% weight on day of discharge, lost about 300 grams. But then by the time baby reached day 7, he regained the body weight. If we have that much of dehydration, there should have been us, which is not there. The thing which bugs me really is the sodium of 155. I'm also not sure what should be your ideal fluid. But with that sort of sodium, if you're giving 1/5, 150, that is a standard. But the sodium of 155, I will be a bit hesitant because it can drop your sodium too fast. But in a neonate, it did not. I mean, your sodium dropped quite gradually. But I would possibly start with half.
We have given isolate
I
pieces.
don't know.
হ্যাঁ একদম ঠিক আছে দেবাশিস দা একদম ঠিক আছে শুরু করুন
Sorry?
We have given isolate pieces and first 1 to 2
Yeah,
days.
that's the point. When your sodium is that high, you are giving 1 pill, which contains only 30 milliequivalent per liter. And your serum contains 155. Big gap, so your sodium can drop fast, and that's a big worry. That's a big worry.
But okay, surprisingly, that and
If it is
that's.
Yeah, that's why I did. Yeah.
I was not.
Maybe it's not about all this.
The kidney must
Yeah.
have recovered.
You mentioned in your slide that the urine volume was 0.34 ml per kg per hour for 8 hours.
8 hours after
So what was that after admission?
after admission we
And given the management, with the urine output had not improved initially,
sir.
suggesting that AKI, you know.
Sir. Okay, sir. Thank you.
Anyone else? So the API was dengue only.
It was a dehydration, madam. Actually, he was having fever for last 2 days, not sucking properly, feed intolerance. So dehydration was because of renal cause. Means reduced intake because of reduced intake.
Which is when that happened. Thank you.
Okay, thank you. Thank you.
সোমনাথ ঠিক আছে তো?
হ্যাঁ একদম ঠিক আছে একদম ঠিক আছে
নেক্সট স্পিকার মনে হয়
Our next case is neonatal sepsis turns misnomer by Dr. Kriti.
Good afternoon, all faculty members and my seniors, my colleagues. I am Dr. Kriti Sundarlal, and I am here with about the discussion of a neonatal septicemia. There are 2 cases which we had admitted in our NICU, and let's see what happened to them. So case 1 was a term child, but it was an IUGR baby, and it was a girl child born at the gestation of 39 weeks. So the child was admitted in NICU on day 3 of the child's life due to its poor sucking and hypoglycemia. So we sent the sepsis screen, and then again we started IV meropenem along with the fluid management, and USG cranium was done. It was quite normal. Fundoscopy was done, and we found there was some peripapillary hemorrhage in the right eye. Later on the day 4th, we found that the child had some deviation of mouth, and on the next day we came across some focal convulsions in the child. 3 episodes were there. That's why we had to start IV phenobarbital in the loading dose and followed by the maintenance dose. The sepsis screen came out to be positive. CRP was 32, and we just investigated for the COVID-19 RT-PCR for the mother, and it was also positive. So few differences came in our mind. One was obviously the septic shock, another was the meningitis, and HI was also to be considered in our mind. Later on, we did some further investigation, the general investigation, where we found that platelet was only 13,000. So we have to recombinate this platelet transfusion. Along with that, we found that total count, leukocyte count was also high, predominantly neutrophil. Culture for blood was found to be negative. Again, we did CSF studies, which were not so significant. So there were some more things we had to think. So again, we did further investigation. So MRI brain was also done, and in that we found that the corpus callosum had some ill-defined intense diffuse restriction, and it was suggested to be due to secondary to the systemic infection. We also did conducted EEG, but EEG was normal. Later on, we had to do the COVID-19 antibody for the baby, and it was found to be positive, and the inflammatory markers were raised. And this is the picture of MRI, and pardon me for the bad quality of this MRI. So we started IVIG, and it was given over 48 hours. And afterward, we also repeated fundoscopy, and this time the fundoscopy was normal, no hemorrhage was there, and ferritin came out to be normal, and pro-BNP was decreased. And also echo was done, but echo was normal. And IV antibiotic has to be continued, considering actually because of this conversion episodes, and one meningitis was also in our thought. So we just completed the meningitic dose of antibiotic. Again, after this period of treatment, we found that baby was gradually having a good suck, good feeding was good, and the baby was discharged later on in a stable condition. There was another case admitted in our ICU, neonatal ICU. This was a twin baby, preterm, and birth weight was only 1.49 kg. This baby was just kept for observation because of low birth weight and preterm, and there was a history of maternal dribbling for more than 24 hours. So we had to send the sepsis screen and started antibiotic coverage also. This time also USG cranium was normal, and child was quite stable and discharged on 6th day, 7th day. But after 7 days, again the child was readmitted for tachypnea. There was a respiratory rate of 76 per minute. Saturation was lower side, and there was some distress. So we started with the HFNO, and this time we did the X-ray, and X-ray was showing right-sided lower pneumonia. There was no associated much fever, and the respiratory distress was persisting. Here the HFNO had to be continued actually. Later on RT-PCR was done, which was inconclusive in the baby, but RAT in the mother was also negative. Now this was also a confusing state. We did all the normal investigation, routine investigation, and further, as there was one more case earlier we came across, so we had also diagnosed for actually we did the investigation of COVID antibody, and it was found to be positive. It was higher, and inflammatory markers, as you can see, it was higher. So again, was it a case of neonatal multisystem inflammatory syndrome? There was a query, and we had to start IVIG. And again, after starting this IVIG, we found the condition was coming down. It was child was becoming better. And finally, actually, there was a lower pneumonia in the child also. So child was O2 dependent for more days, longer days, and gradually, which was weaned off and discharged in a stable condition. So these two cases, one was term, one was preterm, and most probably we had diagnosed it to be as MISN, that is multisystem inflammatory syndrome in neonates. So this can present in a varied clinical manifestations, and terms have little milder form, and preterms have little severer form. There is a mechanism of transplacental transmission, which is less common in term, because of lack of expression of the angiotensin converting enzyme and transmembrane protease serine 2 by the trophoblast, which are the two actual main host membrane receptors for SARS-CoV-2 entry. However, these are the things which are reversed in case of preterm. These are expressed in more amount, and that's why preterms have a more severe form of MISN. So antibodies also may bind to the receptor on the neutrophil and macrophages, causing activation of cytokines, leading to various manifestations of MISN. And it is also postulated that some newborns may develop MISN due to mechanism very similar to MISC, that is in the older children, which is caused by autoantibody mediated immune dysregulation in the response to perinatal acquired SARS-CoV-2 infection. So this is a pictorial representation of mechanism of MISN. There are the features of encephalopathy, seizures, fever is also there, respiratory distress, shock, These features were there in my patient also, but the echo finding was normal in my patient. There are inflammatory markers which are elevated as seen in my patient also, and cardiac markers were also markedly raised. These are the mode of transmission and the similar manifestations in the MIS child. So this is again one more pictorial representation of the time duration, time lapse from the infected mother and non-infected mother. We can see in the group B, mother is not infected, and the red marked mothers are infected, plus they are shown by plus sign. And one child is being shown in the group E, which is shown to be having MISN, and the characters of and the clinical features are being visible in first week only. In the group C, we can see the sign of this multi-system inflammation came out to be after 2 to 4 weeks after birth. So these were classified as MISC. So the take-home message is that we should not overlook any multi-system inflammation, even in the neonates in this post-COVID era. And the timely specific therapy are very important to save the child. I have some references. Thank you.
Yeah, that's the question. So the first case, what was the CRP?
It was 32, ma'am.
32 in the case of neonatal and MISC is a bit low. MISC we have seen hundreds.
Actually, it is 32 per DL. So that works out to be 320.
320.
Yes, ma'am.
And one more question is that it had an encephalopathy. There was no
Yes.
myocarditis, there was encephalopathy.
Yes.
For your first baby.
Yes.
So did you get any steroids for that?
No, we didn't.
Concentrate with it.
Actually, we didn't start the steroid. We tried with IVIG at first, and the result was very good. So we didn't thought to start steroid, as we could have started with prednisone, but IVIG worked. Yes,
So Zetadone is a very good CSF.
yes, we could have started, but IVIG worked very nicely. That's why we didn't.
I would have given both IVIG and steroid because it was a very fulminant course. There was a facial nerve palsy, there was a retinal hemorrhage.
Yes.
Okay. And in the second case, the one with the lung findings, did you give steroids? Because it wasn't prolonged ventilation.
No.
HFNO.
Yeah, the child was on HFN.
HFN.
Second one, return child.
So did you contemplate giving
Actually,
we didn't give the steroid. In that case,
we have seen 2 or 3 cases, MISN, who have presented with bad findings. Actually, MISC rarely presents with lung findings. Usually you get
সেকেন্ড স্লাইডে একবার যাও দেখি, জাস্ট সেকেন্ড স্লাইডে, বাস ফার্স্ট স্লাইডে চলে যাও, ঠিক আছে, মুভ
we have
করছি
seen
ফার্স্ট স্লাইড, ওকে ঠিক আছে, ডান, চলো কন্টিনিউ করো।
I think we could have tried so much.
Why have we given IVIG in the second? I mean, what is the exact indication?
so the inflammatory markers were highly raised in the second case also.
Yes.
And these were the conditions we are comparing with the criteria. Actually, neonatal MISC, multi-system inflammatory syndrome of neonates, still are under study. There is no very actual criteria made for them. So to save the, we had to save the life of the neonate. So actually one case was already there, and this was the post-COVID area. Antibody for the COVID was very high in the second child also. So these were the things in our mind that led us to think that this is a case of MIS. So we thought that IVIG is a good treatment for it. Started.
But there is no hard indication for it. I completely agree. You know, oftentimes you have to play it safe,
Yes.
newborn baby, yeah, but there is no hard indication for it.
Right.
Yes,
Yes.
in the first case, the child got sick at day 3,
Yes. Yes.
and we translated with melodan.
So we went for the sepsis screen actually. And
Is that the first time drug use? That, I believe that's not the first time drug use is happening.
no, sorry.
And it was community approach.
And you gave for 3 weeks, that means you gave in Manjari to 40.
Yes, sir, it was there.
But the child was very many that your CSF was absolutely normal. The convulsions was due to the CNS bleed.
Benefit of doubt.
So this was not the benefit of it. That's why this is not a case of meningitis. We actually thought it was meningitis.
But then still, you manage, still in spite of a normal CSF, you continue. And it's that was the
Just on starting day of antibiotic, we did all those investigations, but report came later on.
Can I ask Suparna and Ogni, these BNP levels, previously we never used to do program.
Yeah, exactly.
Now whenever we do them, they are high. So how high is high?
And then you keep doing.
Exactly, you should know, exactly, that is the thing. The
What
child,
does it take?
what does it help you? The same thing. Is the same thing. Exactly, they are quite costly these cases. I think NT-proBNP comes around 5,000 in the private. Suppose you have it in your
I think
institute.
they have, it's free over here.
Okay, speaking, the আমাদের বাইরে থেকে করাতে it's around about 5,000.
You know, just because it is free, you know, your echo is normal. Yeah, your echo is normal. There was never anything to tell you that there is some sort of cardiac issue there. Why do you, sort of keep chasing up, keep looking at a marker? This drop it. Why why I will not even do it unless I have some little bit concern that maybe my heart is very sensitive, and we don't really know how to interpret those numbers. Don't really understand what those numbers say us.
How long will you continue to do much? That is the thing.
Okay, fine.
Thank you.
Our next case is a tricky case of neck swelling by Dr. Indranil.
Good evening, faculty members and my dear colleagues. The case I am going to present today is a tricky case of neck swelling of a child who came here, 1-year-old child, Nandik Paul, was admitted on 12/9. He was from Barakpur, West Bengal. The informant was mother and he was reliable, and she was reliable. The chief complaint of the child was fever for 10 days, along with the cough and noisy breathing, which was there for 3 days. And the another thing was the swelling, which was over the back of the neck in the midline. And as per mother, the swelling has gradually started increasing size in last 2 days. The child has a similar complaint of fever along with the cough cold 1 week back, for which the child visited the local pediatrician and was managed conservatively by antibiotics and along with the nebulization. In terms of birth history, the birth history, the child was delivered by LUCS at term. The birth weight was 2.8 kg. The significant thing in the birth was the child had a history of neonatal meningitis, for which the child was admitted in NICU and treated with the IV antibiotics. The immunization, the child has received immunization as per his age, and BCG scar was present. The developmental history of the child is as per his peers, and as per family history, there was nothing significant. So we came to the examination findings. The child was active alert. At that time of admission, the child was afebrile. The heart rate was 120 beats per minute. The respiratory rate was high, 38 per minute, and along with the subcostal retraction was there. There was a bilateral lonca in the chest, and per abdomen findings was nothing significant. There was no neck rigidity, and there was no any focal neurodeficit. Then for the swelling, we examined. The swelling was 2 into 2 centimeter in size. Soft fluctuant swelling was there. It was non-tender with diffuse margin and situated in the cervical spinal region. So on the basis of the examination and the clinical findings and the history, we had certain DDs in our mind. The first DD was LRT along with the neural tube. Maybe it is a neural tube defect. Secondary was maybe it's a lipoma or a dermoid cyst. So with those 3 DDs of the swelling, we moved further, and following investigations were planned. CBC-GIP or routine investigation for the fever was planned along with the CBNAT-1 2 blood culture chest X-ray. So these were the investigation reports. there was anemia, the hemoglobin was persistently 9.5, 9.4 in that range, but the total WBC count was high, along with predominantly neutrophilic predominance was there. Even on the that is the 9th of September, the count reached up to 27,000 even, and platelet count was a little on the 6.5 lakhs, 5.5 lakh range, higher side, little bit on the higher side. The CRP was 16, the ESR was 30, and the CVNAT and the MANTU were negative, and the blood CS report came later. We started antibiotic, but the blood report which came later was negative. The USG report which was done showed that there was a spinal swelling of 1 centimeter defect in the posterior element of the upper dorsal vertebra. Approximately thickness was 2.6 centimeter and cystic lesion. So suspicion of the dorsal encephalocele was or meningomyelocele was there. So on the basis of the above reports, the patient was managed conservatively with IV antibiotic nebulization. But on the 3rd day of the admission of the child, since the child has fever, cough, cold, the RT-PCR was also done. So the report came positive, and the child was shifted to isolation ward. The patient there was managed in the lines of COVID pneumonia, but the fever spike continued. So finally, at that time we had a clinical diagnosis in our mind that it might be a secondary bacterial infection in a case of COVID pneumonia, with probably about the swelling, we thought it was a neural tube defect, since the USG report also corroborated like that. So later on, the antibiotics of fever and respiratory distress persisted. So we upgraded our antibiotic to mero and azithromycin finally. So patient responded, and the fever and the cough subsided. And the thing is that the swelling also reduced in size, but did not disappear completely. So finally, as the child was well, so we planned for an MRI, and it was done. And this is the MRI cervical spine findings. We can see the erosion of the cervical C6 vertebra over there. These are the things, and there is also the same. So the MRI report, what came astonishingly for us was the tubercular cervico-dorsal spondylolisthesis at C67 to D3, D4 vertebral region. And there was an adjacent vertebral involvement with anterior epidural phlegmon indenting the spinal thecal sac, causing reduction of the anterior spinal subarachnoid space and bilateral recesses with compression of the corresponding nerve roots as well. So finally, the diagnosis was there for us to do. The diagnosis of the Carey spine was made, and all the antibiotic was stopped. Finally, the ATD was started, and the patient was discharged in a stable condition with the advice of regular follow-up at the DOTS clinic and the pediatric OPD of our hospital. In the regular follow-up, the child has visited our hospital. The child has gained weight of 1.5 kg from his previous weight in a span of 3 weeks. And earlier, what the mother complained that the child had a lost appetite. The appetite also improved considerably well since the treatment with the ATD drugs. And the swelling now has completely disappeared. So the take-home message for us in this case was the COVID pneumonia is a known entity in this COVID era, but we should not forget the TB as an entity as well, since our country is always having a large number of TB patients. So in this case also it was there, and the spinal TB cases does exist in the infantile age group, and the two infections can coexist simultaneously. And if we can identify the Carey spine early, we can start treatment early, and thus we can prevent the neurological complications like paraplegia and all from occurring. So in this case, the MRI is the gold standard, as we know, for any spinal vertebral canal pathology. And many a times we should confirm for any spinal swelling by an MRI, as because USG can sometimes be misleading as well. Thank you. The swelling, as per mother, the swelling was from last 2-3 days. When the child was admitted, the swelling, the mother noticed swelling.
How could you attribute that to neural tube defect at the age of 1 year?
No, that's what we initially thought. It might not be a neural tube defect and might be a some.
Is that a very common case for neural tube defect?
No.
Number one. Number two, you should have gone straight for the MRI.
Yes, no, we should have gone, but the child was very sick at that time, and on the day 3 of the child developed COVID infection, so it was a bit tough for us to do an MRI that time.
Fine, but at any point you should not have thought of a neural tube defect at this place and at the age of 1 year. That was not at all acceptable, isn't it?
But X-ray, because we was also a bit biased after seeing the USG report. Since that USG report gave us it might be a meningocyte. Yes, X-ray of that region. No, after USG we did. We did a chest X-ray on exam, but that swelling.
Swelling is here.
That was missed at the initial stage. Because the child was very sick at that time, so we were always looking for the cough, cold, distress, and all. We were so.
I think we are becoming too much COVID. COVID.
Nice presentation. One thing, why did you do? I mean, why did you do CVNet and Bantu in first place? I mean, I found that a bit, and later on it got to be quite appropriate. But what was your reason for doing?
No, sir.
I was amazed by that.
No, sir. Actually, the CVNet and Mantu, sir, we planned for CVNet. Later on, the child was not improving. So we were giving antibiotics. The child fever persisted. The X-ray findings also showed the features of LRTI. So thought of doing a CVNet.
So you didn't do it. I mean, right straight away. I would not do a.
No, sir. No. After some days of, after 5 to 10 days, we did. Yes, sir.
It was done later.
Later on, as the child was not improving that way. No, no family members were having any contact. Later on, we again asked the family members. No, father told no, we don't have any.
Child responded temporarily to azithromycin.
Yes, madam. And meropenem also, as it was a second line anti-tubercular, imipenem and all. So it was the swelling disappeared.
And puzzled in any way.
Yes. So it was lucky for us that mero and azithro worked, and so fever also responded, and swelling also did reduce.
The current situation, does it cause any neural cord, spinal cord, this in the current situation? Was a neurosurgeon?
No, madam, we haven't. No, there are no neurodeposit. The child was doing well, and I have sir.
Could it have occurred in the next say 1 month while treatment before treatment was effective?
Yes, madam, it can happen if the child if there was secondary drug resistance and all, the child may land up in.
So what man is asking, that was there any element of cord compression or anything?
He said that there was.
Radiculopathy and cord compression was there.
So you not consulted any neurosurgeon.
That was that point of time we haven't consulted.
Very scary that a cord compression can happen at any time. Especially MRI must have had a.
Yes, sir.
MRI.
We given pedigrelin and that was.
Any neck, manipulation, anything. Thank you. Very
Thanks.
fair and.
Yes, ma'am.
Rare presentation of common.
That is articulated in the short one.
Yes, sir. Double screen. Single screen वाले.
You have to share once more, I think.
Okay.
नेक्स्ट स्क्रीन है जाओ नेक्स्ट स्लाइड है
Sir.
इट इज द फर्स्ट स्लाइड हाँ ठीक है फर्स्ट स्लाइड है
ठीक है तो
हाँ ठीक है फर्स्ट स्लाइड है
ठीक है चलो
राइट
start.
Good afternoon, everyone. I'm Dr. Aisha Sadi. After a series of very interesting topics, I'm going to present something that is much more simpler, but I think has a lot of good take-home messages. So, my case is about a female baby of Chanda Singh and Santosh Singh, a very high-risk neonate of twin pregnancy, and we're going to be discussing about twin 2. Baby was conceived spontaneously. Mother was of gravida 3, para 2, living issue 2. Mother had no known illnesses as such. Baby was born at the gestation of just 28 weeks, weighing just 890 grams, appropriate for gestational age according to Fenton's chart. Baby cried after initial steps of resuscitation and was born via vaginal delivery, that is breech extraction. When one unfortunately died intrauterine owing to reversed end-diastolic umbilical artery block. So, as this baby was a very high-risk neonate, we immediately shifted to NICU. Baby was kept euthermic. Baby had mild respiratory distress, respiratory rate around 62, and mild distraction. Baby was immediately started on heated humidified high flow nasal cannula. Surfactant replacement therapy was given using insure technique, and relevant investigation sent and IV fluid started. Since the mother actually had dribbling for more than 48 hours, we started empirical antibiotics in view of clinical suspicion of sepsis. Stopped after sepsis screen and blood culture was negative. Baby developed apnea at 46 hours of life, and injection caffeine was given. But the most interesting part of this baby was that this is the entire treatment that the baby received in our NICU. As you can see, we gave antibiotics only for a short course of 5 days, which is as soon as the culture report came negative, we immediately stopped. And as soon as baby was off oxygen, we started TMC. As you can see, baby was off oxygen support at day 7, and immediately we started candle method care. And also, we started breastfeeding at a very initial stage, that is less than 48 hours. And we followed the protocol of breastfeeding. That is, since the baby was born at 28 weeks, we gave OG feed, and which was changed to case feed at 32 weeks, and again changed to direct breastfeeding at around 34 weeks. And the baby had beautiful weight gain and with minimal intervention. Direct breastfeeding, sir. Direct breastfeeding.
Direct breastfeeding.
Yes, we Katori spoon feeding, sir.
Katori spoon feeding.
We started at 32 weeks, sir. This is 32, as you can see, is the corrected gestational age.
Okay.
And at around 33 weeks, we combined direct breastfeeding along with case feeding cell. And after 34 weeks, baby was completely on direct breastfeeding cell. And NNS is non-nutritive sucking cell. So this is from AIMS protocol. We followed this protocol. And again, as you can see, like I've put breastfeeding and KMC on top just to emphasize how superior it can be if a baby is doing well. So this high-risk neonate needed minimal intervention and gradual weight gain, mostly with the aid of breast milk and KMC. The weight at birth was 890 grams, and we discharged baby at 1,600 grams, even though OFC was increased. On discharge, baby was on exclusive breastfeeding, vitals were stable, and high-risk follow-up, including BERA or ROP screening, USG cranium, and development screening was normal. Immunization was done as per schedule. So the take-home message would be that the breastfeeding, breast milk is the best nutrition. We do not need to rely on top feed or anything of that. And if baby tolerates it, it is definitely at a lesser risk of complications. And the lesser the intervention, the better the outcome. The infections can be avoided. So there was no need for like umbilical venous catheterization or any central line or anything of that sort. And I think we avoided a lot of sepsis because of that. And neonates do not thrive on antibiotics. This baby will be followed up until 18 months of age. So the take-home message is that less can always be more. Thank you.
Thank you.
Thank you.
Let's take
My question at the question.
How about temperature medication?
Baby was kept under warmer, ma'am.
And then why you were doing camera?
Initially, ma'am, we had kept the blowers. And then once the baby gradually increased in weight, we didn't even need the blowers as such, ma'am. So we monitored the temperature throughout.
How frequently did you do bloods on this? I mean, blood investigation.
Sir, starting we had done, sir,
Yeah.
the
And
basic
then,
investigation.
then afterwards.
So we didn't actually do much of investigation, sir, because baby was doing well. There was no indication as such. I think once in 15 days we had sent.
In 2 weeks.
Once in 2 weeks we would send a complete hemogram.
They're looking for.
So normal.
And why you are doing it?
We had actually done only once, sir, after that, because actually we. There was no indication as such, sir. We had just sent once just to like be on safe side.
Because look, I'm not a neonatal person at all. I feel very sort of uneasy when I'm talking about neonates, but I think their hemoglobin can drop quite significantly.
Yes.
Do you monitor them their hemoglobin if they're doing activity fine? Or do you give them iron anyway?
Nothing of that sense.
What about normal supplements? Vitamins, iron?
Yes, sir, we did. So ma'am, we started, we added HMF once the baby was on full feed, ma'am. And vitamin D also within 2 weeks we have started. Vitamin D, tonopherol, and A to Z multivitamin syrup we have given. Yes.
What about vaccination? What is
4 weeks. Vaccination, ma'am, we had given everything apart from Hep B. So the protocol is that you give Hep B once the baby gained 2 kg of weight. So apart from Hep B, we had given the rest of the immunization. Yeah, baby was routinely called, ma'am, according to the protocol.
When is the first
Every initially 1 weekly, ma'am, and then 2 weekly, and then you gradually taper. You give a call after 1 month, and then for routine immunization also we were calling the baby. So every time we did a developmental screening. Currently, like the baby was 4.5 kg, ma'am, and sits with support, ma'am. So